so I'm Debbie Yang. I'm one of the infusion nurses at St. Joseph Hospital. I just started I'll be starting my 43rd year at St. Joe's. And again, I have the honors of presenting Raquel. I haven't practiced her last name, so I'll let her say it. Luague. But she's just an excellent nurse. She's our unit nurse educator. She has lots and lots of experience. And I'll read you her little bio. She is an RN who graduated from Suliman University, Philippines, and we have lots and lots of Philippines that we have the blessings of working with. I'm very proud of who I work with. I'm petitioned by St. Joseph Hospital of Atlanta to work with them since 2002, so she came from the Philippines. She has work experience with the renal and pulmonary unit and CCU at St. Joe's from 2002 to 2008. She started to work with Emory Healthcare 2006 with the renal unit at the main campus, and she's been at St. Joe's Winship since 2018. She's married. She has 2 sons, and she loves to cook and travel. Let's all welcome Raquel.
Good morning, everyone. Okay. This is more like sharing of ideas because I know all of us here are experienced nurses and you have a lot of tricks up your sleeve. So if it will not be mentioned here or if it will be mentioned, elaborate with me because this is more the focus of this endeavor. We sharing what we know with each other. Okay, so before we go to that, I know the St. Joe's folks, anybody that's not from Emory, welcome. And Joa?
No.
Okay.
So I'm an oncology nurse here for my position.
Okay,
Yes.
welcome,
Yeah.
welcome. And
Nurse educator liaison for pharmacy.
awesome, because we always coordinate with you guys when we need help. We do. I actually have one scheduled for like next week. Yes. So thank you for coming and thank you for enriching our education as well. So what you have there are little care packages and we'll talk about it in a little bit because those are our magic tricks that we try to share with our patients that may also help with their pharmacologic journey to help with the nausea and vomiting, okay? So chemotherapy-induced nausea and vomiting remains important because it has still affected continuously our patients. Whether we will like to believe it or not, we have a lot of things that we can give. Give them this and that. But then it's still kind of a quote-unquote plague for our patients. Not necessarily when you are giving the infusion in the outpatient world, but when they go home a few hours later, they tackle with that. And that's why it's still one of the most feared, quote-unquote, side effects that patients, especially cycle 1, day 1 patients, come in and have anxiety about. The nausea and vomiting. It's not the pain. It's not the loss of life because they're still very hopeful that we can help them. So we as oncology nurses can play a significant impact on how to improve outcomes related to this most anxiety-provoking, if not feared, side effects of chemotherapy. This is my war call. Let us embrace the guidelines. Let us scrutinize the guidelines. And let us think outside the box and listen to what others, that includes patients, have to say about alternative support therapies. So briefly, as I go through today's interaction, I will talk about the pharmacological part. But then my question is, what more can we do? We always ask that of ourselves. And nurses, as creative as we are, I've never seen so many creative people. We always try to find ways and means. And that's why I want you to share with each other too, what are those creative stuff you've had? Okay? So let's go ahead. Of course, I'm required to have objectives, but I could just have a chat with you guys and still learn. We have to apply knowledge of CINV prevention in patient management. Explore CINV prevention and management trends in clinical practice, and create a customized CINV mini plan of care, but not the formal one. We'll just talk about it, interventions and all. So, definition of terms. Nausea. We all know about it. So we have to remember, for this group of patients, they are not plagued more with vomiting. Nausea is the dinner. Because most of the time, they're having nausea, it's not usually with vomiting. With the nausea, I'm feeling sick, I don't want to eat, I don't want to drink. You hear that all the time, right? It is an unpleasant, subjective experience that is described as wave-like feeling occurring in the stomach and or back of the throat that may be accompanied by vomiting. But for our patient population, mostly they wake up in the morning, they feel sick, and you tell them, okay, take your Zofran. I'm about to have breakfast. They take it and they have breakfast immediately. What are we supposed to do? Wait a minute. Wait, correct. We have to make that drug available in the bloodstream before it can work. Retching. I thought that wasn't part of it. I thought it was just nausea and vomiting. But then you hear the next door, well, I'm outpatient. So like the next bed. It happens all the time. I'm laughing, but it's no fun for that patient. And it's actually no fun for me because then here's me. He's retching. What can I do? Can I get ginger ale? Can I get something? Oh, I need to get him a vomit bag just in case. So there's a lot going on in our minds. Right? I can see nods and smiles because we are all very caring and compassionate nurses. Arrhythmic contraction involving the esophagus, the diaphragm, and abdominal muscles. It's more or less like a concert of the GI tract. In the attempt to eject stomach contents, retching in the absence of vomiting is known as dry heaving. Oh, he's just heaving. So then the next one is the vomiting part. This is, if we are having the concert, it's like the final act. Forceful expulsion of gastric, duodenal, or jejunum contents through the mouth. Ta-da-da-dan! And we feel for the patients. Every single time. Hydration, shall we give them fluids? But then you really feel bad about the patients, right? Can you imagine this? We're just with them for a few hours. Inpatient, you're just with them for a few minutes and you're going to the next patient. How do you feel if you were that patient? I see all your faces. You've answered my questions. Now, I would like to briefly show you how our medications or how nausea and vomiting happens so that the medications that we give, we know they work. But the how, I know most of us probably know too, so this might just be a review. Okay?
The vomiting center, which is located in the brain, is the central area responsible for CINV. The vomiting center is made up of neural structures involved in the vomiting reflex and is located in the fourth ventricle and brainstem, and also with multiple afferent nerve fibers associated with it. The vomiting center is near the respiratory center and is activated by visceral and vagal afferent pathways from the GI tract, the chemoreceptor trigger zone, or CTZ, the vestibular apparatus, and the cerebral cortex. The vomiting center has sensitive neurotransmitter receptors to chemical toxins like chemotherapy, which are located in the blood and the cerebral spinal fluid. The vagus nerve plays a key role in vomiting related to chemotherapy. Chemotherapy and radiation to the GI tract or the gut stimulate enterochromaffin cells, which release serotonin or 5-HT3. Serotonin release then activates the vagus nerve, which stimulates vomiting through the chemoreceptor trigger zone or the vomiting center. Serotonin is what is involved in acute nausea and vomiting. We will now look at some proposed CINV pathways. It has been hypothesized that chemotherapy administration induces CINV by activating neurotransmitters in the GI tract, but also activating neurotransmitters in the chemoreceptor trigger zone via the blood or cerebral spinal fluid. Multiple neurotransmitters are involved in the CINV process. Stimulation from these neurotransmitters, the chemoreceptor trigger zone, the vestibular apparatus, and the vagus nerve signal the autonomic system, causing nausea, and the somatic and visceral systems, causing vomiting. Even memories, such as anxiety, anticipation, or fear, can trigger nausea and vomiting via the cerebral cortex. We will next look at the risk factors associated with CINV.
In short, we have two, like our body is ganging up on us. We got the central one and we have the gut. The gut is mostly related to the acute vomiting, which is within 24 hours. The central pathway, which is like, it is responsible for the delayed vomiting. Okay, so they were mentioning about neurotransmitters. There are 3 major neurotransmitters that are affected by the CINV. They are, serotonin, the substance P, and dopamine. Serotonin is otherwise called as the 5-HT. Familiar with that one? And then we have our 5-HT3, which is our medications that we give. We'll go to that in a little bit. So those are the main 3 receptors. So the substance P, we use medications that we call NK1. We love this one. Just hold on a bit. So you see this very simple diagram, but it kind of profoundly captures where we intervene. Chemo medication, we have substance P from the brain, serotonin from the stomach, and then forget about the intervention first. That leads to NK1 receptors. They pair together, and then we have nausea and vomiting. But then in between the pairing, we put our medications so it doesn't happen. Our medications take the place in the receptor sites, so we prevent nausea and vomiting. Okay, now we will proceed with the different kinds of nausea and vomiting. Anticipatory, especially cycle 1, day 1. Have you noticed this on your patients? See, I love that. So, what do your patients usually say? Cycle 1, day 1, they're coming in. Anybody? I need a soloist, not a choir member. The only gentleman in the room? Yes, Lisa. Can you imagine the immensity of that fear? And when you're afraid, I don't know about you, because like right now, I haven't had anything except water because I'm so nervous. I'm feeling nauseous. So then they are nervous for their lives. They are anxious. What's going to happen? There's so many more questions than answers. That would really be anticipatory vomiting. I'm anticipating that what I will see in this infusion center is just like what I see in the movies. All the time they say, oh, I thought it's such a dreary and gloomy place. And trust me, because St. Joe's Infusion Center is run by the Filipino mafia. A patient told us that it is loud, crazy, and everybody is just laughing. So they say, oh, this is not what I thought it would be, which is a happy thing for us. Acute vomiting happens, as I said, in the first 24 hours, and we have medications for that. Delayed vomiting is after that 24-hour period, we have medications for that. Breakthrough. That's the thing we're in. We give all our medications, but the patients are still vomiting, are still having nausea, are still affected, and they would come, what? You lost more than 10% of your weight? Oh, you need to go to the ER. Because they don't drink, they don't eat, they don't want to move. Refractory is the worst one. Because then they would keep, despite everything that we do. At least in the breakthrough, they keep vomiting. We can still find other alternatives. Any questions so far? We're on the same page. Awesome. Now, there are risk factors. Do you realize that the nausea and vomiting of the patient, I think you do, we're causing it big time. Iatrogenic. What does it mean? It means it is caused by something medical. We are causing it. If we're not friendly, we're adding to the anxiety. If we are apathetic, whatever, okay, the same, patient B has the same symptoms as patient A. Okay, I'll give you your medication. Hey, the same medication, different compassion, that wouldn't work. We need that sense of compassion with that medication. Trust me, what did Tim say? Love should be an ingredient of it. Any kind of love. Maybe it's your love for your break after you take care of this patient. That still works. What break? Radiation. I didn't realize it. Because all I can remember is like radiation now burns and stuff like that. But apparently, radiation therapy causes 50 to 80% patients on radiation therapy experience nausea and vomiting, especially with the body parts that they are exposing to radiation. The trunk, upper parts, they are more prone because there's more body surface area that is being exposed to the radiation. That's one of those. Others that may or may not be related, but post-operative nausea and vomiting. We have those when they are having surgery, surgical oncology nurses. We have those for those patients. Add on the chemotherapy after surgery. Add on the anxiety. No family support, let's not go there. So next one, we have also opioids. Our patients are in pain, remember? And then the opioids, they slow the gut. Guess what happens? Nausea and vomiting. That's for iatrogenic. Patient-related. I love this part. Females are more prone to having nausea and vomiting. I thought I'm more special than that. Who have children? Did you have nausea and vomiting during pregnancy? You're more prone to having nausea and vomiting when you receive chemo. Yes. Who is 60 and below? We are more prone to nausea and vomiting. Who drinks alcohol? Who loves it? Who loves it? Who loves it? Maybe that they say I know, right? Yeah, whatever we say here stays here. Let's create this a Vegas. What happens is, it's probably because of desensitization. If you are an alcohol drinker, your nausea and vomiting is diminished remarkably. Unfortunately, we cannot say drink more alcohol to diminish your nausea and vomiting. We cannot do that. Yes. There you go. Yep. So that's one of the patient-related factors. There are others, those with dizziness, motion sick, yes. They are prone to develop worse CINVs than others. Then we have disease-related. You have to remember that when your patients come to you, sometimes we forget. We just say, oh, do you have side effects from your medications? We forget that, oh, this patient is diabetic. This patient have anticoagulopathy disorder. This patient is hypertensive. Sometimes we forget that until we have like, oops, I can't give the Avastin. What? Your blood pressure is 180. Oh. That's only when sometimes when we're so rushed, we're juggling so many patients and so many diseases, and sometimes like, oh, sorry, forget what I said. You go to the next bay. This is the patient that needs this information, especially when they have more or less the same regimen and the same. Forget what I said. Yes, you have to tell them erase, erase, erase. Okay? So those are some, because diabetics have gastric paresis. That increases that. Hypertensive people, they get dizzy. Their blood pressure is not controlled. Aggravated on that one. Okay? So those are some of the things that we will have to take into consideration when we are taking care of these patients, how bad their nausea and vomiting can be. So in assessment, determine the potential causes of nausea and vomiting. So we go back to here. These are physical causes. Where's the tumor? Do we have gastric paresis? We got constipation. So these things should be considered in our assessment. Metabolic causes. Do we have fluid electrolyte imbalance? Because the patient already is too anxious to even eat or drink. Medications that aggravate other than chemotherapy. You got your antibiotics, you got your opioids, you got your targeted therapies. Biotherapies plus chemotherapy. Because you cannot let them, like, patients would come into us, they have comorbidities that they're taking 1 million medications already. And you can't stop that. We have to make sure to safely give our portion in their care, but at the same time, keeping the balance of the care of other providers to holistically care for our patients. Psychological causes. This is like more hidden, so we have to be more intuitive and more compassionate. Because then when we're more compassionate, we're more connected to our patients, and we can easily like, I see, he's not usually like that. What's going on? Because you would say just, hey, good morning, how are you? I'm Raquel, I'm your nurse again. But if you don't pay attention to the subtle cues, we will miss an opportunity. Let me go back to slide number this. Identify the specific type of nausea and vomiting because they have different causes, remember? Then if they have different causes, then we will try to intervene based on the causes that they have. If it's anxiety, I've always proven it to be effective. I literally sit with my patient and ask my coworkers, they were, where's Raquel? Where's Raquel? It's like, she's chatting with those patients. I played games with my patients. They have this sequence game, and my patient was so anxious because I'm a hard stick, even with my port, hard stick with a port, and so then I say, oh, what's this? Oh, sequence. Oh, teach me. Oh, it's like, the other was like, it's like mahjong. I said, I can play that. Come on, let's try to. A few minutes, I just actually stayed there for like 4 minutes. Played like one deal, and then the patient was so much better. And she was chatting. Remember that patient in 9? We were like, she was laughing like a high school girl. 3 minutes of play. Identify the nausea and vomiting grade using CTCA. There's an app for that. Really, there's an app. Go into your care packages. I have a little card there for you. Smells good, right? That's John Creek's research. I'm trying to, yes, uplift our coworkers who have also done a great job. If you open it, there's the CTCA guideline for nausea and vomiting. So you see grade 1, they have signs and symptoms, but they can intervene at home. They can probably take fluids, but please remind them that fluids, because a lot of patients think that when you tell them fluids, it's just water. You really have to, I realized that the hard way. You have to really specify. I said, really? I have to tell them you can have soups, watermelon, that still counts as fluids. You have to. I realize it, that we have to really specify. And they say, Italian ice. Oh yeah, Italian ice, because it seems like they tolerate it better. Popsicles. Yeah. So they can tolerate that better. So those are your guidelines, but if you want more for other side effects, you can download the CTCA app, and it's gone by systems. It's really very helpful. Determine the level of emetogenicity. We may not have the time, but I have a handout there that determines the level of emetogenicity, which means to say if they're high, like cisplatin, chances are we need all 3 of the major antiemetics. Okay? So it depends. And later, if we will have time, we will play a game. It's really fun. So I have that there for you. And then there's also a guideline on interventions if they are in a certain kind of emetogenicity. It's like table 37.4, recommended guidelines for treatment in your handouts. So the list of medications is both for oral and parenteral. So that if we are clinic nurses or we are inpatient nurses that give oral medications, oral chemotherapy, we would know which level those medications are in terms of capability to cause nausea and vomiting. Yes. Correct. Thank you, Debbie. So those are some of the things. And the other thing too is like maybe they were listening so fast, or they were listening, but other things are bugging them. So you have to remember that when we give information to our patients, especially the first few meetings, you will be lucky if they retain 5% of that information. So then the next time the patient comes in, cycle 2, day 1, they said, I don't know. I picked up this from pharmacy, but I didn't know what to do with this. Guess what? Dex. Correct. So we really have to really find time to itemize whatever may be intuitive for us. Just like this gentleman here, computer is intuitive for them, but not for old mama here. Okay, they're laughing because I think we're the same boat, right? So, any questions in terms of that? We're good. Awesome. So we have discussed that. And then what are our potential complications? This is the sadder part, and this is the part that we can be there for them. Withdrawal. Have you ever had patients that like, I need to see you all the time because if you're having a reaction, I need to see black and blue face, flashed face. What do? Close the curtain. What can we do? Pick. We always take turns. Hey, are you okay? We are not supposed to close curtains, but we have to kind of meet each other halfway. Because otherwise, we will not be effective. If we insist and be master surgeons instead of nurses, our effectivity plummets. Delay of chemotherapy treatment, because if we have nausea and vomiting, guess what? We're not having anything, and if we are not hydrated, if we are not eating well, our numbers go bad. The doctors say, you're not well enough. Let's not have treatment today. Let's wheel you to the emergency room and get yourself hydrated. Or even in the hospitals, right? You delay treatment once they are not up to it, where a certain level. Nutrition depletion, that kinds of explains dehydration, nutrition depletion, anorexia, weight loss. We see all that because of the nausea and vomiting. And then we have deterioration in of course, I know I love to eat. Can you imagine if I cannot eat even if I want to? The torture. I will be tortured if not. But then, like say for example, I know that's gonna be coffee. I can imagine the smell already. Ooh, that would be. But then when you are having nausea and vomiting, what happens? Yes, you kind of like, oh, it doesn't make sense. Your brain is telling you lies. It doesn't make sense. Why does coffee not seem appealing? It's just because you have all these acids coming up, and that's all you're tasting, and that's all your brain is sensing. Discomfort, of course, and of course, interference in the quality of life. You don't have energy. You don't want to socialize. I don't want to be bothered. I just want to curl up here and try to ride on my nausea. Straining abdominal muscles, increased intracranial pressure because of the... And then aspiration. That's worse. We don't want that. Aspiration leading to aspiration pneumonia. You're getting in there. You're going to be intubated if it's really bad. Ooh, bad picture. What's our goal? Prevention, prevention, prevention. What if we are in the middle of nausea and vomiting already? Preventing the worst for them to happen. Sometimes we can't avoid it. What can we do? With all best efforts, superhero powers. we still have to intervene and try to come up with the outcomes that would be best for the patient. Select antiemetics based on emetogenicity regimen and depending on chemotherapy or radiation. Consider additional risk factors that may increase likelihood of nausea and vomiting. We've discussed that. And antiemetics selected on suspected etiology. Nausea and vomiting persists, add another antiemetic. Still persists, add. But you can only add so much. That's why they have adjuncts. That's why we do Pepsid, because then it helps block the receptors too. That causes acid production. So we have the pharmacologic guidelines that you have there. And then the more fun part and the more creative nurse comes out. Who plays music? Look at that. Music therapy, especially for anticipatory nausea and vomiting. Haven't you noticed the young ones are in their earbuds all day long, listening to music? Call them. Nathan. 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 No, Nathan does not hear me. Imagine I'm in front of him. I'm calling him on my phone. That's the only way to stop that music, because they are diverted. And that's the same. They're focused on the music and they're enjoying it so much, they forget everything around them. And that's the intent. Our patients might get diverted and forget that, oh, by the way, I have nausea and vomiting. I love my music. Oh, I have Andre Bocelli. Oh, I forget my nausea and vomiting. Then, a lot of people are going back to ancient East Asian traditions, Eastern traditions, acupressure, acupuncture. I tried to look, oh, there is such a thing as electroacupuncture. They just use the regular TENS machine, put it on those acupuncture needles, and let it vibrate. Like electricity. Little things like that. Well, patients swear. I have patients swear to it. Can I disagree with that? Can I challenge that? Of course not. Because that is their perception and that's how they would. I'm happy that they found something that would work for them. Guided imagery usually, that's one of the behavioral interventions, and guided imagery is usually given together with music therapy. Then you will be guided. Okay, you are in this. Think of the most happy place you've been. Not your kitchen, not your bed. Dietary. They say bland diet. Our patients actually don't know sometimes that it's a bland diet because things are so pronounced. Things become too salty. Things become too sweet. But that's the recommendation. Bland diet, and then we will have Mediterranean diet are also recommended for patients who are having this. And there are studies that say powdered ginger is recommended 500 milligrams twice a day, and it is incorporated in whichever drink or food, and it has dramatically or significantly diminished the nausea and vomiting of those patients that were in the study. Then, that's why in your care bags, I don't have the powdered ginger. I have a more fun one. You got your ginger chews. And patients say the Quizzy drops really help them. And then the lemon ginger tea, because others think that the ginger tea also helps. And then the warmth of it comes down your stomach. Then
Johns Creek, a few years back, had a study in relation to peppermint oil. Our Johns Creek. So they had peppermint oil dropped on a washcloth that's wet and then put it on the patient, and it seems to relieve. They have significant findings that it relieves the patient. So I have a little canister there with peppermint oil. And we've used that with some of our patients while we were preparing it in the infusion center, and they really were like, oh, this is cool. It really helped. Even for a 24-year-old guy, I was so happy because they are hard to please. And then having a log, nausea, vomiting log, helps you identify if you have a pattern, if there are triggers that are more than others. Okay, this is just a sample of what the doctors see and order. So you see we have gemcitabine. It is in the low risk. We only have one antiemetic medication. We got the Xeloda and oxaliplatin. It is in a moderate. You got those medications at home. And then this one, if anything with cisplatin, anything with adriamycin, it's always high emetogenic. So we have all this slew. That's not even the pre-medications. The pre-medications, we will have that one there for high risk. We always have those Emend, the NK1, and then Aloxi, which is a serotonin 5-HT3, but it kinds of like dual phase. It is for acute nausea and vomiting, but it lasts long enough to kind of like capture the delayed vomiting because it lasts for as long as 40 to 48 hours in effect. Emend lasts up to 72 hours. Then, of course, our helpers are steroids, the dexamethasone. Okay? And then we have, this one is moderate, I think. For low risk, you only have one. Sometimes you don't even have any pre-medication. So if you've noticed it, if you refer to your guidelines, you will understand more how our medications are ordered by our doctors. And then nowadays, they add, for the anxiety, the Ativan or olanzapine, that also helps. So we're slowly recognizing that, yes, it really plays, the mental state of the patient plays a great role. Okay? Those are my acknowledgments. That's my friend Katie. And then I have a lot there. So we will say, I declare that I am a healthcare professional. Based on MASCC ESMO guidelines, please select the type of chemotherapy the patient is having. This is our case study. Ms. Jones, 66-year-old, is newly diagnosed with cervical cancer. Her history showed that she had nausea and vomiting during the first trimester of her two pregnancies. She drinks alcohol beverages 2 to 3 times a week. She gets sick when traveling via water transportation, but does fine when traveling by land. For her treatment, the provider recommended that her regimen will be bevacizumab, paclitaxel, and cisplatin. During the rooming in process, the nurse found that Ms. Jones hardly slept the night before in anticipation of today's infusion. She kept saying that she is concerned of the nausea and vomiting that she thinks will definitely happen to her because, quote unquote, that's what happens when you get chemo. Sounds familiar? She repeatedly verbalized. So let us enter the information in the CINV risk tool to find out. Please select the type of chemotherapy the patient is scheduled to receive. So we have bevacizumab. Yep, what else?
cisplatin, and paclitaxel. Okay. And then, what's the current cycle number? Cycle 1. Then we go next. What is the patient's gender? Goes by the pronoun he, she, her. What is the patient's age? So good memories. I'm impressed. Does the patient expect to develop CINV? Awesome. Did the patient have morning sickness during prior pregnancy? Yes. Did the patient sleep 7 or more hours the night before? After the previous cycle, so that doesn't apply. So if you see it's grayed out. Is the chemotherapy anthracycline or platinum? It's pre-populated. Once we enter the medication, it gets pre-populated. And look what our score is. High. And it even says you can give 5-HT3RA plus DEX plus NK1RA plus minus olanzapine. And then plus consider adding a further antiemetic due to the patient's risk levels. It's fun, right? You have your, I like this tool because then it makes sense to me. So you can have that, you can easily access it in the website. And that's all I can share with you folks. Thank you so much.